Who among you remember the 70s? Who were not too inebriated or stoned? Because later on, at the end of this talk, I would like to call upon you, the 70s child, to help me here. Okay. So my talk for the next 45 minutes will really be, hopefully, a very, very practical approach to using advanced PAP therapy. Okay. And rather than give you a sort of theoretical approach to it, what I would like to propose today is to give you 10 simple rules to follow. And hopefully at the end of these 10 rules, you'll be able to use this therapy tonight, okay, for some of your patients. I have to also disclose that technology is a double-edged sword. Okay. Used appropriately, it can be very helpful and beneficial, but also, if misunderstood, can be harmful. So let's take this technology and use it properly, and hopefully this next 45 minutes will help that. So the first rule is quite simple. It's know your patient, right? Know your patient. Let me give you an example of what I mean by that. So this is a true-to-life polysomnography tracing. So at baseline, this person has pretty severe sleep disorder breathing with an apnea hypopneic of 140. Most of the events that, as you see, are obstructive apneas and hypopneas. There were some centrals even at baseline. Per protocol, CPAP was started at 5, reducing the AHI slightly, increased to 7 and 9, and you see a dramatic drop in the AHI. However, the AHI remained elevated even at 9. A further increase to 11 resulted in a paradoxical increase in AHI due predominantly to an increase in central apneas. This led to the addition of oxygen at 2 liters. It fared poorly. And finally, at the end of the sleep study, the sleep technologist was frantic on what to do and tried BiPAP and equally was unsuccessful. So those of you who might be a sleep technologist at night, or worse still, the next day technologist judging the previous night's performance, might consider doing a few things, right? So just a show of hands here. Who among you would continue CPAP but go back to a lower setting? Okay. Who among you would push it even higher, assuming that some of the central apneas may actually be hypopneas? Okay, you would. Who would add more oxygen from 2 to 4? No one. Who would stop the CPAP and bring the patient back after a few days and titrate again? No one. Who would switch to BiPAP, add oxygen, and put a backup rate? No one. Okay, who would choose an ASV? Okay. Okay, so. Obviously, no. Obviously, obviously, the answer. I'm only kidding, Shara, please.
No, that's fine. I tell you something that this study is so poorly done. There are no conclusions from it. And your answers were absolutely appropriate because the study was so poor, and I don't know where it was done. But this is bad titration.
Okay. So Jarok emphasized the fact that it was a bad titration study. So like most of us Monday morning, we call it Monday morning quarterbacks. Okay, we know that it's a bad study. What I was trying, again, I apologize, I was just having fun. What I was trying to emphasize though is that any of this could be a right answer if only we know what the patient is, right? So imagine this patient is a 44-year-old female, healthy, who simply snores and living at altitude like Denver. Treatment would be very different. On the other hand, if this is a 68-year-old male, heart failure with dyspnea, then clearly you have a different approach. or 25-year-old male, chronic pain or narcotics. Okay. Let me add 3 more scenarios. 71-year-old male, stroke with limited mobility. In fact, this patient cannot even put the mask on himself. Okay. Or, and which is what I think most of you think this patient is, a 59-year-old, middle-aged, obese, snoring with apnea. And finally, let me add a 69-year-old female snoring with insomnia and extreme anxiety. Okay. So clearly, your approach to that PSG tracing should be modified and should be influenced by the patient. Because if you look at textbooks, if you look at lectures, if you look at articles, there is always a distinction between central apnea, Cheyne-Stokes, obstructive apnea, and hyperventilation. But the reality is that in many patients, all 3 of them occur in the same patient. Okay? Let me give you some examples. In heart failure, for example, or complex sleep apnea, you will see evidence of both central and obstructive. In advanced COPD, you may see obstructive and hyperventilation. We refer to that as overlap syndrome. And all 3 could occur in somebody on high-dose opioids, stroke, or having a neuromuscular disorder. Okay. Rule number 2. After understanding the patient, understand the patient's respiratory physiology. Let's take the case, for example, of complex sleep apnea. So somebody at baseline has either mixed or obstructive events due to upper airway occlusion. You apply CPAP to open up the upper airways. But in so doing, CO2 is reduced below apneic threshold, leading to the first central apnea. Now this event here, okay, we will again meet as we move along. During the central apnea, CO2 rises slowly, reaching threshold again, causing breathing to resume. However, instead of breathing normally, there is hyperventilation, leading to a reduction once again of CO2 below threshold, leading to the second central apnea. So this event here not only initiated the first one, but is probably responsible for multiple central apneas occurring the rest of the evening. We need to understand what this is, okay? And there are many reasons for that, okay? Dr. Javeri yesterday alluded to the fact that when you have upper airway obstruction and you're struggling to breathe with every event, if you open up the upper airway, okay, work of breathing diminishes and CO2 production may drop. That may explain part of it. There's also concerns that there might be an improved physiologic shunt that may temporarily alter breathing mechanics. And there's also this element of loop gain. Okay, now loop gain is such an important concept, so allow me to provide 3 analogies that can explain this concept better. The human body is designed to follow a norm. Okay? So if our body temperature becomes too high, we become too hot, okay, we take steps to cool ourselves down. We vasodilate, we sweat. Okay? On the other hand, if we get too cold, the body also protects itself by increasing heat production, and we vasoconstrict. So we maintain a fairly stable range of body temperature. We see the same phenomenon occurring, for example, in potassium, serum sodium, bicarbonate, oxygen, and finally carbon dioxide. Okay. So we like to maintain that central mean of normalcy. If you take an example of the room temperature here as your body, okay, and imagine there's a thermostat here, we could easily think that the thermostat is set, for example, if this room temperature is, I don't know, 70 maybe, we could easily think that the room temperature probably, the thermostat is set to between 69 and 71. Okay? So any temperature change beyond those thresholds will cause the heater or the cooler to kick in. So if the temperature goes up to 72, okay, it gets too warm, the cooler will kick in. And if it goes down to 68, for example, somebody opens the door and the cold air comes in, the heater will kick in a bit. And that's good, because then we all of us here are comfortable. In contrast, if I change the thermostat and made it so sensitive to change at 69.9 or 70.1, okay, anytime somebody breathes here, anytime somebody passes gas here, okay, whatever you do, okay, it will kick the cooler or the heater on. Cooler and heater and cooler and heater. You become very, very sensitive, you become very, very twitchy. Okay? So that's one example of an abnormal loop gain. The second example, imagine if the thermostat, instead of being right here in this room, is across a hallway in the next building. So it will take a while for any room temperature change to move across the hallway into the next hall building for it to alter the room temperature here. In human physiology, we sometimes refer to that as circulatory delay. Okay? And that's bad too, because then the response to any temperature change will be either delayed or inappropriate. Then finally, imagine instead of being in this room, we are in a big stadium, okay, that can hold another 10,000 people in, or we are all like sardines stuck in the ladies' room there, right? Imagine the change in temperature if one or two people just move in and out. In the stadium, we can add hundreds and hundreds, and the temperature will remain stable. In that small room, we add one or two people, and the temperature will change tremendously. So that principle of loop gain is very important, because what happens now is if you were to eliminate upper air obstruction, instead of the body, again, breathing normally, which it ought to do, what happens now is that they hyperventilate. They overreact, they become overly sensitive. And by so doing, they push the CO2 down, okay? CO2 goes down, they have an apnea. Apnea becomes overly long, CO2 okay, increases again, and they hyperventilate again. Okay? So instead of being a normal respiration, they go from extremes of hyperventilation to central apnea. Okay. Let's take the case, for example, of heart failure. Okay. I mentioned yesterday that there is a rule of thirds that we think occurs in heart failure. That 1/3 of patients have central apnea, 1/3 of heart failure patients have obstructive apnea, and 1/3 have no sleep disorder breathing. I also told you yesterday that this is probably due to many factors. What I would like to propose today is that these events can change in the patient over time. In fact, can change during the course of the evening, and indeed will change with treatment. So let me show you some examples. This is a study done by Umino, okay, on 57 subjects with heart failure. And what they did was quite interesting. With heart failure, what is your essential feature of heart failure? Think about it. Fluid overload, right? So during the day, as the patient walks around, fluid goes to the legs and you have pitting edema. You have swelling of the feet. And at night, when they lay flat, the fluid gravitates cephalad, okay, and the fluid can go from the legs anywhere up in the body. It can go to the neck, it can go to the lungs. If it goes to the lungs, we refer to that as nocturnal paroxysmal dyspnea. They have shortness of breath at night. Or orthopnea. They have a hard time laying flat. Okay. So what the investigators did was that they divided the patients, the subjects, into two. One group had apnea that were predominantly obstructive in nature, and one had apnea that was more central in nature. And they measured leg fluid volume, they measured leg circumference, and they measured transcutaneous CO2. Transcutaneous CO2 as a surrogate for pulmonary edema. Because if you're pulmonary edema, you tend to have rapid shallow breathing and you blow off your CO2. Okay, so they measured, again, leg fluid volume, neck circumference, and transcutaneous CO2. And what they found out was intriguing. So this is a change in leg fluid volume here. Yeah. This is obstructive apnea, this is central apnea. This is change in neck circumference. And you will see that in both subject groups, there was a correlation between the change in leg fluid volume and the neck circumference. In contrast, this is the change in leg fluid volume again. This is obstructive and central apnea. This is transcutaneous CO2. You will see that the relationship exists only in one group, central, and not the other. Furthermore, if you look at the change in leg fluid volume here, and this is no sleep apnea, obstructive and central, you will see that the highest change in leg fluid volume, meaning the most flow volume overload, okay, was found in those with central apnea. And if we were to plot again, this is change in leg fluid volume and the apnea hypopnea index, you will see a big difference between obstructive and central. Now the question that should be posed at this time is whether treatment of heart failure with better drugs, better diet, salt restriction, if a patient improves with this change there, meaning with the central apnea component, Cheyne-Stokes breathing, become obstructive. Okay. On the other hand, if you have somebody with obstructive apnea and they have worsening heart failure, probably from another ischemic heart condition, would they become more central? Okay, so with this process, I lost my mark here. Would this process be a bidirectional thing? Keep that in mind. A second study I'd like to share with you is done by Ryan using the CAN-PAP data. Again, 98 subjects with heart failure and central apnea, and pretty severe heart failure. Okay. And what they did was they looked at the patients before and after the study with CPAP, and they found out that there is a certain group of patients, okay, where it started with central apnea. This is the dark portion of the bar here. That at the end of the study, continued to have central apneas. Okay, here. Okay. But there was a certain group, 18% to be precise, that had centrals to start with. Okay. That at the end of the study became more obstructive. Now, what happened to this group? This is important. Okay. When what they found out was that it was only in that group, the group that they converted, that there was an improvement in heart function. And let me just show you another quick study. This is Servo. Okay, I showed it to you yesterday with this. This is Servo in severe heart failure, and showed that Servo can improve ventricular function, BNP, which is a biomarker for heart failure, symptoms of heart failure based on the New York Heart Classification, and cardiovascular events. Okay. Complex apnea, I defined this earlier, is development of central apneas during CPAP treatment. So that CPAP will eliminate obstructive events, but at the same time, central events will either persist or become worse. This definition has changed somewhat through the last few years, because we've seen this event also occurring not during the first CPAP titration night, but it may emerge months after during CPAP treatment. It has also been described after upper airway surgery. It has also been described with the use of oral devices. So it's a phenomenon not restricted to the first study night using CPAP. There are many names for this: CPAP emergent central, CPAP persistent centrals. What I like to call it is complicated sleep disorder breathing. Okay. Whatever the name you choose, it has always been considered part of central apnea. Okay. However, if you take a step back and do a blue sky approach to this and look at all the studies, you seem to have a sense, okay? There seems to be a sense that this complex apnea resides in a space between an extreme of obstructive and the extreme of central. They seem to lie about here. For example, they are less obese than pure obstructive apnea, okay? But they are more overweight than central apnea. Okay. They have more snoring than central. They have less heart failure than central, and they have higher ejection fraction than central. So remember the Rhine study and the Humina study where they move from central to obstructive depending on the severity and control of heart failure. Okay. What I'd like to propose that perhaps in that transition from one extreme to the other, you're encountering complex sleep apnea. This is an important slide, and you will see our friend here. What is the prevalence of complex sleep apnea? Okay. It was high when you studied them initially in the laboratory, okay, between 5% and maybe 20%. Okay. But clearly, if you study them again, okay, the numbers really drop down to 1.5, 2%. There's also quite a large differential. Think about this. You have somebody who is sleeping in your laboratory, okay, having severe apnea, and then you wake them up. Okay, and you put the mask on. Okay. And what do they do sometimes? They struggle, right? So instead of going back again into what we call rebound REM or rebound M3 sleep, they stay in stage 1. Okay? They wake in stage 1, they struggle, they wake stage 1, stage 1. And they have periodic breathing. Okay? So that, I think, is not complex sleep apnea. To the extreme, you will see some patients who panic. You put them on a mask, they panic, they have anxiety, okay? They blow up the CO2. Again, I don't think that should be considered complex sleep apnea. Yet there are others where they have such a variable upper airway control that they may have obstructive events when supine and more central hypopnea type when non-supine. Again, one has to be very careful. I don't think that should be considered complex sleep apnea. What I'm trying to propose today, though, when you look at complex sleep apnea, one should think of it as probably a transitory phenomenon. What do I mean by this? This is the transition between your central and obstructive in heart failure. Okay. It is also a transitional phenomenon, meaning you can see high prevalences on the initial study. It will drop when you follow them over weeks later. And it's transient, meaning it can occur in N1 street. It can occur in periodic breathing during early light sleep, but it will probably disappear with deeper sleep. So one has to be careful that we do not think of complex sleep apnea as a fixed disorder. Okay? Rule number 3, select the appropriate therapy. You know the patient, you know what's going on in the patient, now you know what to select. And it's very simple. There are 2 modalities that are advanced. One is called ASV, servo ventilation. One's AVAP. It's really a BiPAP. We'll talk about that. If you have periodic breathing, choose servo. If you think it's inadequate ventilation, support ventilation with AVAPs or BiPAP AVAPs. Okay? Very simple rule. For example, what is periodic breathing? Well, complex sleep apnea is one of them. Cheyne-Stokes is another. What is inadequate ventilation? Advanced COPD with hyperventilation or obesity hyperventilation syndrome. You choose the treatment based on what the patient has and how the patient is breathing. Rule number 4, you know the patient, you've chosen the device. Please, I beg you, do not start learning to use it on the night of the study. Okay? Do not open the manual and start reading it in front of the patient. Learn how to use it first. Okay? It's very simple. So if you turn on the machine, this is what it is. So there are 2 types of servo ventilation, BiPAP and DPAP. They have different targets. One is peak flow, the other is minute ventilation. And I like mnemonics, so a very useful mnemonic if you want to is BiPAP is made by Respironics. So if you spell Respironics, R-E-S-P, peak flow is the target. Okay, VPAP is made by ResMed, so R-E-S-M, minute ventilation is the target. Okay. The EPAP, okay, is automatic, and you see the EPAP ranges there. The pressure support, you see the ranges there too, and the rate. Okay. You don't need to memorize this. Okay? And what I'm going to show you is that this is what a servo does. If you see obstructive events, okay, upper airway occlusion, what the machine does, it increases the EPAP. It's like an APAP, increase the EPAP to open up the upper airway. If you see periodic hypopnea, okay, it will increase pressure support, inspiratory pressure support. If it sees hyperpneas or hyperventilation, it will decrease your pressure support. And if it sees impending central apneas, it may increase the backup rate. So what it does is very simple. So you have hyperpnea, patient's breathing fast, decrease the pressure support, breathing diminishes. After a few minutes, after a few hours, if it sees hypopnea, increase the pressure support. Again, see hyperpnea, decrease pressure support. So you see the cycles of hyper and apnea, and they will respond slowly, and over time, they will become less and less and become more and more stable. Okay. Rule number 5, turn it on. Okay. Technology can scare us sometimes. When I first purchased an iPad for my wife, she didn't turn it on for a few months. She was afraid of it. But turn the machine on, and you will see when you turn it on, it's quite simple. These are the initial settings, for example, for the BiPAP Auto SV. Okay. You have an EPAP minimum and maximum. Okay. This is nothing more, by the way, than your APAP. It's an automatic EPAP adjustment. Okay. It is a range for pressure support, minimum and maximum. Maximum pressure. It's a rate and a biflex. That's all you will see in initial settings. Okay. Again, EPAP, which acts like an APAP, pressure support range, maximum pressure, rate, and an expiratory pressure release. Okay. So what does it do? Like I mentioned earlier, Respironics RESP uses peak flow, okay, and Resmed RESM uses minute ventilation. So if you take one example of this, the target is peak flow for the BiPAP Auto SV. It's a 4-minute moving average. It's also weighted. So it sees what's happening in the last 4 minutes, okay, and adjusts to it. But it puts more weight in the most recent minute than it does the 4 minutes that occurred earlier. So if they have a very, very erratic breathing 3 minutes ago, but more stable now, it will respond to the more stable breathing that occurs more recently. In contrast, if it was stable then, but more erratic now, it puts more weight on the more erratic breathing that occurred more recently. The settings are automatic. EPAP is automatic, pressure support is automatic, backup rate is automatic. Okay? Very, very simple. Rule number 6, you have the patient, you have the right technology, you think, okay? You turn the machine on, the patient is now using it. Be patient. We have been trained, okay, all of us, to respond to the patient's need. Okay? We want to address the CPAP, control all hypopnea, we add oxygen, control hypoxia, but in this case, be patient. Okay? Allow time for the patient to adapt to the machine, and allow time for the machine to adapt to the patient. Okay? It takes time. In fact, one of my students, I'm very proud, told me one day, he said, when I turn the machine on, I just look away, get my coffee and come back. Okay? It takes time. Okay? You do not want to be the overly reactive thermostat that the patient has. Okay? You do not want to go there and start twitching things around. Let things settle down. Make proper adjustments though. Okay? So you have 3 responsibilities during the night. The first is you have to have a patient that likes your treatment. If you came to me the next day with a CPAP titration that shows that apnea hypopnea index was normal, but the patient cannot stand the servo settings, you have done nothing. You have accomplished nothing. Okay? Because the patient will never use it. What I would rather have is for the patient who likes the setting, who's comfortable with it, who can sleep with it. The AHI may be slightly high. I really doesn't matter because I can change that over time. And by the way, over time it can change too, right? So your first responsibility is to choose a setting that the patient would use. Therefore, if they're unable to sleep, there's a few things you can do. You can add some biflex or expiratory pressure release. Okay. It makes the breathing more comfortable. Your second responsibility, by the way, is to eliminate all upper airway obstruction. If you see apneas going on, obstructive apneas, then by all means increase the EPAP. Do not allow the automatic settings to persist. If they're reaching 10, don't allow the EPAP minimum to be at 4. Increase it. Eliminate all upper airway obstruction. If there's no upper airway obstruction and they're unable to sleep, make it more comfortable. Increase the pressure support minimum. In fact, what I would recommend to all of you is get one of the servo, try it on, and play with the settings. You will see which settings are more comfortable for you, and you can use that for your patients. Keep it comfortable. Number 8, prioritize goal. Okay. So we're close, so don't worry. We're 2 more, 3 more. Let me show you a patient. 70-year-old male who comes to you with a simple complaint of snoring and daytime sleepiness. However, when you take a history, you find out he was a lifelong smoker and has advanced COPD. Because of the smoking, he also has multiple ischemic attacks and now has poorly controlled heart failure. He also has morbidly obese with clearly defined obesity hyperventilation syndrome. Because of the weight, he hurt his back, he's now on high dose of opioids. And because of the COPD, he couldn't sleep at night, and somebody's giving him high dose sedatives for insomnia. What do you do? What you do is you send this patient to your next laboratory, to the next physician in line. But it's clear, what do you do here? Okay. Because you have a few things to tackle. First of all, you have to understand you have to take care of hypoxia. You have to understand you have to take care of upper airway closure. And you really have to take care also of hyperventilation. So among the 3 here, which one would you need to tackle first? So again, I mean, ask the audience, who among you thinks that you should correct first the hypoxia? Adding oxygen, okay? Who do you think should correct first the upper airway closure? Okay? And who do you think should treat first the hyperventilation? Okay? And I agree with the majority, by the way, okay? Because you have to open the upper airway first. There's no way you can control breathing and oxygen without opening up the upper airway. That is your main responsibility. And how do you do that? Increase the EPAP. Okay. Once the upper airway is open and you have periodic breathing or inadequate breathing, that's when you control your pressure support or your rate. Between the 2, I prefer pressure support. Okay. I'll explain that why with COPD, but let me explain to you right now for complex sleep apnea. Like I said, it is a transitory, transient, and transitional phenomenon. So therefore, you do not want to you want to avoid, by the way, a controlled mandatory breathing. You do not want the rate to be so high that you're breathing for the patient. So I can do that with BiPAP, right? I can do that with BiPAP with a back rate of 20 and patient breathing at 20. There's no advance at all. But if they improve, by the way, it's very uncomfortable, by the way. Try yourself. Put yourself in a high backup rate with a small tidal volume. It's very difficult to breathe. Okay. So, but also, if you put them on a high backup rate and they improve, if they improve, you will never see the improvement because you are breathing for the patient. Okay. And if they have hypoxia, still, after controlling the upper airway and the ventilation, then by all means increase EPAP. By increasing EPAP, you may increase lung volume, okay, we call it FRC. You can also increase pressure support, increasing tidal volume, and you may also add some oxygen. Okay. Hypoxia can be rather daunting because when patients are hypoxic, they can hyperventilate. Okay. And that simple fact can lead to central apnea. Okay. So if they're hypoxic, and adding oxygen alone may be sufficient once you control the upper airway and control ventilation. So during the night, here you are, somebody's comfortable during the night. Again, like I said, your second goal is to keep the upper airway open, and if it still remains closed, increase EPAP minimum. If you see central apnea is occurring, increase pressure support maximum. So if the patient is having hyperventilation and central, and your setting is only here, right? You want to envelope the entire cycle of hyper and hypopnea for the machine to stabilize things. Okay? Increase the pressure support maximum. And as a last resort, you may think of setting a higher backup rate. Rule number 9, know when and why you failed. Now, what's failure? First of all, what's failure? If you come to me the next day, somebody has a sleep study the night before with servo, and they are very comfortable, they woke up refreshed, they like it, they like the experience of the servo, all the upper air obstruction is gone, obstructive hypopnea and apneas are 0, they have some centrals persisting, AHI is still about 15. Am I happy? Yes, I'm happy. That's not failure for me. However, that may be a failure for your primary care physician. They will say, wow, Dr. Hill, you came to me with a patient AHI of 20, you put a patient on servo, AHI is 20. You did nothing, okay? But look, here, tons of obstructive apneas, here none. Here patient sleeping poorly, sleeping well. Poor efficiency, great efficiency, right? So you have to define what failure is, and you have to define that for the primary care physician. Look for underlying morbidities. You may need to correct for, poor control of heart failure. You may need to reduce opioids, and that's the next talk, by the way. There's always this concern that should we switch to the other ASV device? It's hard to recommend that because, like I said, the patient has changed, okay? And changing from one device to another really doesn't make much sense. What I would like to recommend, though, for everyone here is for you to understand very, very well the technology of one device, because that's what your go-to device will be. But also understand the other device, because you may have a patient from another sleep laboratory coming with their device, and it's very difficult. I know there are some formulas to switch pressures from one to the other, but I really don't like those. So understand both technologies and use the right tools, because you may be choosing the wrong device if you're somebody who's hypercapnic. For example, severe COPD, obesity, neuromuscular disorders, or chronic use of opioids. You may be dealing with sleep-related hyperventilation. And this is the definition. What's the problem with this definition? Is that many laboratories are freestanding and have no access to blood gases. Many sleep laboratories, even in the hospital setting, do not have people who can come in at night to do the blood gases. So if you see sleep-related hyperventilation, it's mostly clinical. Okay, mostly clinical. I do advise, however, that for most sleep labs, if they have the resources, to get either a transcutaneous CO2 or end-tidal CO2. Okay. Because if we have this, then clearly servo is the wrong device. And you will have to consider using some sort of targeted tidal volume pressure support. Who among you understands BiPAP? Who among you understands BiPAP? It's a very simple concept, right? BiPAP, 2 pressure. A high inspiratory pressure, IPAP, and a lower expiratory pressure, EPAP. If you understand BiPAP, you should understand pressure-targeted pressure support. Okay? It's very simple. So you have essentially a BiPAP. This is your BiPAP, 8/4. Okay? This is your BiPAP here. But what you have too is you have a range of IPAP. So the BiPAP can go from 8/4 to 10/4, 15/4, until 25/4. Okay? And this is your rate. This is your inspiratory time, your rise time. And what you have to do then is to provide a tidal volume. Why is it important? So if you have, let's say, a BiPAP setting, let's say this is 8/4, okay? And this is your desired tidal volume. If the patient hyperventilates, let's say during REM sleep, and drops the tidal volume, here, get it here. What this 8/4 will do, we increase to, let's say, 12/4. You increase the tidal volume a bit, we go up to 15/4, okay, until such time that you will get back to your desired tidal volume. That's all it is. This is your EPAP setting, which is automatic, and this is your varying inspiratory positive airway pressure. So how do you set your desired tidal volume? You can either use a formula, 8 ml per kg. What I prefer to do is bring the patient in early, put the mask on them, and adjust the pressure. Okay? And they will tell you. They will tell you whether the pressure is hard to breathe or excessive. Okay? And you find the right spot there in between. And most of the time it is 8 ml per kg plus minus 1 or 2. Okay? It's right there. Okay? Or you may ask the physician, because the patient may have, let's say, a pneumonectomy or recurrent pneumothoraces or a paralyzed hemidiaphragm that might alter your desired tidal volume. During the night, if you see obstructive events, you have to increase EPAP. Okay? But by increasing EPAP, remember, you have to maintain your pressure support. When you increase EPAP, please increase also your IPAP minimum. So if your IPAP minimum, let's say, is 8 and your EPAP is 4, if you need to increase your EPAP to 6, don't keep it at 8/6. Increase it to 10/6. Maintain your pressure support. If you see hyperventilation, I recommend increasing pressure support. You want to increase the tidal volume. Simply increasing the rate when you have a very small tidal volume will only ventilate your dead space. Okay, because you have a very small tidal volume. You have to have enough tidal volume to create alveolar ventilation before you increase your rate. And then finally, if you have hypoxia, increase the EPAP. Like I said earlier, it will increase lung volume, pressure support, rate, or add oxygen. There are multiple studies using BiPAP AVAPs. Okay, you see here obesity hyperventilation syndrome. You have mixed, you have COPD, advanced COPD, and there was one case of a central hyperventilation syndrome using this. Just a very, very simple graph here. This is a small study on 10 subjects with obesity hyperventilation who failed CPAP. You will see that the transcutaneous CO2 here at baseline with CPAP, BiPAP, spontaneous time mode, and BiPAP, spontaneous time AVAPs. Okay, it does really work. Okay. Rule 10, monitor your patient. Okay. Remember, the patient that you will see again in your clinic is a different patient now, changed by the underlying treatment that you provided and changed by the underlying morbidity that you're trying to treat. Every patient who comes to you back in clinic is a different patient. Okay. So again, take a good history, review the medications, review your PAP settings, and change accordingly. Okay. To summarize, we start with knowing the patient. We end by re-knowing your patient. Okay. I hate to go through this. Instead, because I like the audience a lot, they have been very, very quiet the last 45 minutes. I'm going to summarize this talk instead by singing a song, okay? Which I call the ASV song. And those of you who remember the 70s, hopefully, please sing with me. And those who don't remember the 70s, just ignore me. Okay. It goes like this. You can stop these apneas, Shane Stokes and Central. ASV will help your patients with heart failure. When you use it during study nights, you realize everything's alright. Try. Several ventilation, reduce readmission, enhance ejection fraction. As you choose your patients, keep this on your mind. It works on complex apneas most of the time. Through the sleep nights, if upper airways close, increase EPAP and make it comfortable. Add several ventilation, control respiration, improve sleep consolidation. Thank you. Any questions? Not about the singing. Yes, sir.
With allowing for patient comfort and other factors, I prefer to recommend it for bypass of any sort that have at least a delta of 4. I would agree with that or have
Your question is at least, right?
well, right. In other words, the generally, I'm thinking the generally obese patient that or
So there are two types of clinicians. One, I think we call the conventional low targeted tidal volume clinician. And I, on the other hand, I refer to myself as a high intensity targeted tidal volume clinician. So I like massive tidal volume. Okay? I'm more of a European, German, British high pressure support thing. There are multiple studies now, at least A, advanced COPD, and B, in obesity hyperventilation syndrome, where they target either using AVAPs, okay, a tidal volume of 8 ml per kg, or they target a tidal volume of a minute ventilation of 110% of baseline, and show that the outcomes are better. So I like high pressure support. Okay. Now your question is, of course, different. What is the minimum pressure support that you need? Most books refer to 4, and I'll tell you why. Okay, but I rarely use just 4. I rarely use just 4. The 4 tidal volume, the 4 pressure support minimum that people have been discussing really refers back to, and again, Dr. Hill and Dr. Javeri may correct me. There is some concern when the devices were applied with FDA. For example, let me ask a question. When you use APAP, right? APAP, what's the minimum APAP setting? Well, APAP's 4, right? Well, APAP's 4. Automatic pressure is 4, right? So why is it 4 and not 3 or 5 or 2? Okay, the answer is really simple. So when you use CPAP or APAP, you have a single tube, okay, and you have a passive expiratory port, which means that you have to expunge, okay, the exhaled air with every breath, especially CO2. And data that was supplied to the FDA in 1996, using the worst reasonable case scenario. These are patients who you might see in the clinic. Okay, it was felt that 4 cm of water was sufficient to purge the CO2 with every breath. Now, like I said, that's a reasonable worst case scenario. You can have somebody with a very, very bad lung that may require more than 4 to purge them. Okay. That is the very same reason why we think that a pressure support of 4 would be sufficient to ventilate a patient. The second reason is that if you have a very small pressure support, then the technology that you want to use is probably not the right technology. You can get by with CPAP. Okay. Dr. Hill, any?
What?
Good question.
Yeah.
Why is BiPAP minimum set of 4?
4. You said it.
Okay. Okay.
Clears the, it's like breathing through a hose if you don't have some kind of exhalation.
Yeah.
CO2.
So there were attempts in the late 80s and early 90s to create two tubes, one to breathe in, one to breathe out. Also attempts to create an active expiratory port to suck the air out with every breath. But then it became too bulky and too expensive. And you will have a device that's really created for the ICU, very, very expensive device, rather than for the home, which is very inexpensive. Yes?
So I just make this comment that, so, can you hear me?
It takes a while. Yeah. It takes a while.
Can you hear me?
Yeah.
So, however, when you think about an ASV device, and now I'm talking generic here, because there are really major differences between the two devices. But anyway, when you think about ASV device in regard to your question, the difference between now the bi-level and the ASV is as follows. So you could choose a minimum pressure support of 4, but because you have automatic inspiratory pressure support and your maximum, say, is 10, you really don't have to worry about that anymore, because if there are events such as hypopneas, automatically the pressure support will go up, in contrast to having a fixed inspiratory pressure support. So that is really the benefit of ASV versus over the bi-level, where the pressure support is fixed, but in the ASV now the pressure support can go up above the minimum to the final amount of maximum you have set it in response to respiratory events.
What Shorrock is saying is that the device now is highly intelligent. And it will do most of the work. But you know, we have to understand why it's doing that. It's very important to understand why it's doing that. Any other questions? Yes? So the question is whether when you have hypocapnic central apnea, which is central sleep apnea in complex sleep apnea, what increasing the CO2 by other means, right, medication or increasing dead space would regulate your breathing. And the answer is yes. Okay, there are multiple studies in Boston, for example, showing that. There's some studies also in the West Coast showing that. However, this is my bias. This is my bias about that, and I'll give you 4 biases. One is that we really do not understand the adverse effects of hypercapnia in these patients, okay? And whether they have any adverse effects on heart physiology. We do not. Okay. Secondly, like I said earlier, this is a transitory, transient, and transitional phenomenon. So if you have a fixed dead space, okay, you may fix that during the night, but as they improve or worsen over time, it's very difficult to adjust them. Okay, so you have to convince me that you have an adjustable dead space device that can do so. Thirdly, the CPAP is not just to control breathing. It also has positive effects, if used properly, based on the CANPAP data, on the heart function. Okay, so if you use the CPAP properly and you're able to improve preload, afterload, and cardiac contractility, like we have shown here, then I think that's a better use of technology than just simply diamox in dead space. Okay. And then finally, we have a multitude of data supporting benefit with this technology, and we have less of that. So over time, we may see more dead space research coming out. But today, I think our responsibility to the patient is to provide the best care based on the best evidence. And today, I cannot see that with diamox in dead space. Again, my bias. Yeah.
Can you hear me now?
Yep. That was a question with multiple layers. So if you have obstructive sleep apnea that goes on some kind of therapy, such as CPAP, and now there are emergent central apneas, I think now there are 3 studies that really indicate that the use of CPAP is adequate in many of them, and that the central apneas will go away. So this CPAP so-called emergent central apnea has occurred in OSA patients post-tracheostomy. And there are 2 studies on OSA patients who underwent tracheostomy and had repeated polysomnographies after tracheostomy, and the central apnea generally went away. In kids with tonsillectomy, they get central apnea, they have obstructive apnea, got tonsillectomy, they develop central apnea, go away. Oral appliances, same thing. So this is an emergent central apnea, which has its own mechanisms that we have discussed in the literature several times, but it's generally transitory. So that's a very important point that that Lee was making. It's a transitory phenomenon, and therefore be patient and encourage the patient to use the CPAP, make adjustments as needed if the pressure is too much, for example, change the mask, for example, and it normally will go away. And the study that Lee was showing to you, we had 1,200 patients over a course of a couple of years, and we demonstrated in the ones that came back, indeed it go away. Then there was the study just published in Sleep by the Mayo Group, who really advocated ASV device for these patients to begin with. And we wrote an editorial on this, and I encourage all of you to read this paper and the editorial that accompanied that. And that was a randomized controlled trial on complex sleep apnea, OSA with CPAP, emergent central apnea, and they randomized either to continue CPAP or continue ASV for the next 3 months. And they concluded that ASV was superior to CPAP in this group of patients. However, if you read our editorial, you can see that really the differences were quite small. And when they looked at quality of life, this and that, there was no significant difference in either group. And the residual AHI was very, very close, although significantly higher in the CPAP group, not surprising. But there were other issues that we discussed in the editorial. So really, the best thing to do, be patient with these patients, not to put them on Ambien, long-term Diamox, dead space, this and that. You really need to be patient, and these things normally will go away. They remain, it remains a subgroup that it may not go away, and then you have to see exactly what is going on, how significant that number is it few central apneas, who cares about it? Patient is doing very well. Index is 10, 12 per hour on the download, who cares? Let things go. Now, if the patient is not doing very well, the AHI is very high, then you have to decide what you want to do. Should you go to ASV or should you do something else? But in general, I don't want to subject my patient to long-term benzodiazepines, long-term acetazolamide, long-term, this and that. I mean, I have done randomized controlled trials on acetazolamide, on Teofilo, published in journals, and they have their own side effects. Benzodiazepines are associated with long-term side effects. So I think it is inappropriate that do these things in one night. In fact, that's why I thought that first study that Dr. Chiong was showing to us was poorly done because there were too many switches. And at the end of the day, you look at the study, you can't conclude what needs to be done. So I am very patient, and I encourage my patient to use the CPAP, mostly go away, and then I'll decide 2 months down the road what needs to be done, depending on how the patient is doing and what the download AHI is.